Hello and welcome to Season 2, Episode 12 of the Physician Assistant Exam Review Podcast. This week, we're going to get back into GYN with ovarian disorders and pelvic inflammatory disease. My name is Brian Wallace. I'm your host and creator here at Physician Assistant Exam Review, and I am looking forward to getting back into the swing of things this week. Last week, we took a little bit of a break. We moved into some of your questions. We stopped talking about GYN, mostly because I was very sick and didn't have time to put the stuff together. Thankfully, I am feeling so much better. I had an extremely bad case of bronchitis. It's taken me about 4 weeks to get better, but finally, I'm much improved. I actually have a friend at work who's in the same situation, and she's still struggling, getting better, but struggling. So it's a nasty bug that's been going around, but thankfully, I'm over it. My wife didn't get it. My 2 kids had it earlier in the summer, so I think we're just about done with it. I just hope that she doesn't get it, but I think she's out of the woods now because it's been a little while. So hopefully we're gonna pull through. Anyway, this week we're gonna jump back into GYN and continue with ovarian cysts and pelvic inflammatory disease, and that's gonna bring us much closer to the end of GYN, OBGYN. I think we only have another maybe 1 or 2 more episodes that are going to include that. I'm not even sure. Anyway, I just wanted to mention before we jump in and get started, Val and Kim are both taking their exams. I think it's this week or the beginning of next week. So good luck to you guys. I really look forward to hearing how you do, but I'm sure you're going to do great. Please let us all know. We would love to hear how you make out. But good luck. Congratulations on making it this far. Like I said, I'm sure you're going to do fantastic. So without further ado, let's jump into our priming questions for this week. You discover a small ovarian cyst in a 27-year-old female. What's the best initial treatment? Small ovarian cyst, 27-year-old female. What do you do? My answer for this one is watchful waiting. I'll explain that a little bit more as we move forward. So we'll leave a little room for discussion on that one, but watchful waiting. What's the hallmark physical exam finding for pelvic inflammatory disease? A hallmark physical exam finding for pelvic inflammatory disease. Cervical motion tenderness. What age group is most commonly diagnosed with ovarian cancer? 60 to 75-year-olds. What 2 organisms are generally the cause of pelvic inflammatory disease? What 2 organisms are generally the cause of PID? Chlamydia and Neisseria gonorrhea. All right, so let's jump in. We're going to begin with a discussion about ovarian cysts. This is something I see very, very commonly in my practice. I do a lot of GYN surgery. I do a lot of, in fact, tomorrow morning I have a patient I'm going to help remove an ovarian cyst from. And these can be very, very common. They're a normal part of the menstrual cycle, so this includes follicular cysts and corpus luteal cysts. So you can just see on ultrasound, you can see very normal, very functional cysts, especially in a workup for something entirely different. So a lot of times patients come in with a imaging study that shows cysts in their ovaries, but the problem with that is it can often be, like I said, very, very normal. The most common types of benign cysts outside of those normal functional cysts are serous and mucinous adenomas, teratomas, and dermoid cysts. I don't think we need to go into a whole lot of detail about each one and what they are. The dermoid cysts are the teratomas and dermoids are the ones with the teeth and hair and nails and fat in them. Those are pretty nasty to take out. They're just gross. Another one would be an endometrioma, which is endometriosis on the ovary, has created a cyst, and that's what are called, sometimes referred to as chocolate cysts, because the fluid inside of them is really old blood, essentially. So it's just the syrupy, dark, chocolatey looking stuff that pours out of them if you make an incision into the cyst. So they're sometimes referred to as chocolate cyst. In a postmenopausal woman, an ovarian cyst is presumed malignant until proven otherwise. Obviously, they're not going to have functional cysts. So anything that's going on there is a real problem and needs to be worked up immediately. Clinical presentation, why do patients come in? What's the complaint? What's the problem? Usually pain is going to be your presenting symptom, abdominal pain, pelvic pain, that sort of thing. They may also have abnormal menstrual changes, so something else to pay attention to. And like I said earlier, can certainly be an incidental finding in a workup for something else entirely. In fact, I think I have a good friend now who is pregnant, and they discovered on her ultrasound that she's got a big ovarian cyst. So there's some questions there about how to handle that situation and moving forward. It's never bothered her. It's never been an issue. Who knows how long it's been there if it's not, but it is pretty large. So that's part of the concern there. Physical exam findings. It's possible to palpate a very large cyst. If you have something like that, like a 10 centimeter, 8 centimeter cyst, you may feel it on a bimanual exam. I wouldn't count on that as your diagnosis. For your real diagnosis, you're going to use an ultrasound, and they're going to give you the details about the size and locations of any cysts on the ovaries. Exploratory laparoscopy, if you have a patient that simply has pelvic pain, a lot of times we'll go in, if it's undiagnosed and we can't figure out any cause for it, and they've had their ultrasound, they've had everything else, we'll go in with an exploratory laparoscopy and look around, and sometimes there is an ovarian cyst. Treatment. Like I said earlier, watchful waiting in a young person with a very small cyst is perfectly normal. The most common of these are those functional cysts, so it's not a big deal. You keep an eye on them. You get serial ultrasounds to follow them, make sure they're getting smaller and not bigger, and then that's just the treatment. Otherwise, you are going to go in and take these cysts out. If they're causing some kind of a problem, mass effect or pain or anything along those lines, we're going to go in and do a cystectomy. Typically, that's laparoscopic, so we put a scope in and a couple of instruments, and we go in and we either drain the cyst or take our shell out the cyst wall and make sure that we get the wall out, because typically it'll come back if you don't get the wall. If you just drain it, the cyst may reform. But anyway, so it's really pretty straightforward. Ovarian cysts, they're diagnosed with ultrasound and they are removed laparoscopically. Ovarian cancer, this is something that's pretty fairly rare, but is really tough to diagnose in clinical setting. But you're going to get a few clues on a test question about it. So like I said earlier, most of your patients who are going to have ovarian cancer are going to present from age 60 to 75. In practice, it won't, typically it's patients older than 45 years old. Some of the risk factors that are going to be included in any kind of question on ovarian cancer, the patient will have increased ovulation. What I mean by that is they have a longer period of ovulation and they don't get a break from it. So early menarche, so having your period beginning your period menstrual cycle very young, not having kids, and then very late menopause will increase your risk, just like it does for some other GYN cancers. Caucasians have an increased risk of ovarian cancer. A family history of endometrial cancer or a family history of ovarian cancer certainly puts you at a higher risk factor for ovarian cancer. The clinical presentation is the real problem here for diagnosis. It's very vague and subtle. You get a bunch of weird GI symptoms that have trouble placing. Typically, the presentation is very late in the disease process. They can have pelvic pain and pelvic pressure. But again, there's no clear indicator in a history or really in a physical exam that are going to give you clues for ovarian cancer. So it's going to have to be something in the top of your mind when you start seeing vague abdominal symptoms in somebody who's postmenopausal. For your physical exam, you're going to do a bimanual, of course, and you may be able to palpate some kind of a mass, but again, that's not going to be how this is typically diagnosed. Patients may have ascites, that's possible, something you can notice on a physical exam. Labs and studies, CA-125 is used to monitor treatment of this, but it's not used for a screening test. It's most helpful for postmenopausal women, as premenopausal women have elevated CA-125 even with benign disease. So the CA-125 is going to help you to monitor the treatment, but again, it's not something we use as a screening test at this point. Ultrasound, again, going to be helpful here for our diagnosis, laparoscopy, and then a CAT scan. Treatment is going to be removal of fallopian tubes. The treatment is going to be a total abdominal hysterectomy and bilateral salpingophorectomy and lymphadenectomy. So we take everything out. The uterus, the ovaries, the tubes, and some lymph nodes. What I briefly misplaced in my notes is that what we've started doing is taking out the fallopian tubes. Let's say we do a hysterectomy and the patient wants to keep her ovaries. If it's a younger patient, for example, a 40-year-old patient who's having menstrual issues, so we go in and we take out the uterus. We've also started a lot of the surgeons I work with have started taking out the fallopian tubes. And the reason for this is it's thought that may be the ovarian cancer starts with the fallopian tube. So by pulling those out, you drop a lot of new studies that have come out show a decrease in ovarian cancer in patients who do not have fallopian tubes. So we've been beginning more and more to take those as a part of a routine hysterectomy. The treatment's also going to include chemotherapy, radiation, and the 5-year survival rates on ovarian cancer are about 45%. So not great, but again, these present very late. The symptoms are very vague. Something, if in your clinical practice, definitely pay attention to, but especially on your exams, you get vague symptoms in someone who's, roughly just postmenopausal. You should be thinking ovarian cancer. Our last ovarian issue we're going to talk about today is polycystic ovarian syndrome, PCOS. Polycystic ovarian syndrome. Clinical presentation here is a patient who does not menstruate enough, oligomenorrhea, or doesn't menstruate at all, amenorrhea, and is infertile. Usually that's when patients present is because of infertility. Physical exam, the patients tend to be obese. They tend to have excessive facial hair, so hirsutism is the term for that. Virilization, so more male characteristics. Labs and studies, you're going to get an FSH and an LH. This is to check premature ovarian failure and hypogonadotropic hypogonadism. You're going to check their TSH level, so the thyroid stimulating hormone. DHEAS, this is used to test for adrenal neoplasms. A glucose tolerance test. A lot of times PCOS patients have an issue also with diabetes and processing blood sugar properly. A pelvic ultrasound may show the polycystic ovaries, and you may do an endometrial aspiration to help to define this. Treatment. Initial treatments are going to be things like weight loss and starting metformin to help with the glucose control. If the patient desires pregnancy, if she wants to get pregnant, clomiphene is used to stimulate ovulation. Dexamethasone, 0.5 milligrams PO at bedtime with clomiphene increases ovulation rates. So dexamethasone and clomiphene together. If the patient does not desire pregnancy, medroxyprogesterone, 10 milligrams a day for the first 10 days of each month, and this will cause regular shedding of the endometrial lining. So it's, or you can use oral contraception. So basically you get a cycling, and it helps to regulate the hormone levels and will help to have these patients go through a regular menstrual cycle, because a lot of times they don't. They'll either menstruate, once every 3 or 4 months or not at all. So you want them to be going through that regular menstrual cycle. And then for obvious reasons, you're not going to want to use birth control if it's someone who's trying to get pregnant and show up into your office with the chief complaint of infertility. Our next topic for today is going to be pelvic inflammatory disease. This is a polymicrobial infection of the fallopian tubes and pelvis, and this can be really, really nasty and cause some long-term issues. This is usually caused by sexually transmitted organisms like gonococcus and chlamydia, like we said at the very beginning. Those are going to be our two main culprits, are chlamydia and Neisseria gonorrhea. And I just lost my place in my notes. Where are they? Clinical presentation. Here we go. They may come in with a fever, with nausea, vomiting, purulent vaginal discharge. That goes along with the two bugs that we have here. And then bilateral pelvic or abdominal pain. So one of the clues to PID is they've got pain all over the place. This is not limited to one side. So this is not a torsed ovary. This is not a appendicitis. It's not one-sided. It's bilateral, and there's pain all over the place. So that's going to be one of your factors. It's going to help you on exams to tell the difference between PID and some other things we've had going on. The purulent vaginal discharge will also be of value. On your pelvic exam, cervical motion, tenderness, they're definitely going to hurt with that, just like they would with the cervicitis. Uterine tenderness, adnexal tenderness, friable cervix, and again, that mucopurulent discharge. Those are going to be your clues as to what's going on here. Labs and studies, a cervical gram stain and culture. Again, we're going to see chlamydia and gonorrhea. An ultrasound can help us. A coldocentesis, so placing a needle into the rectovaginal space in order to culture the fluid there. I haven't seen that done. It sounds pretty invasive, but certainly helpful in making that diagnosis. An MRI, we can wind up doing a laparoscopy. If there's no improvement in 48 hours with antibiotics, it's recommended to do a laparoscopy to visualize abdominal and pelvic structures, as well as to obtain cultures and really get a good idea of what's going on. Again, we're trying to rule out appendicitis, ectopic pregnancies, and ovarian torsion, and that one-sided issue is what's going to help us with that. Treatment. So mild cases can be treated with oral or IM injection of antibiotics. Ceftriaxone, I'm going to run through the list here. You may want to check out the website because you're going to have a hard time memorizing it just based off of me saying it, but checking it out, reading it might be more helpful. And this I just pulled off the CDC website of the current recommendations. That's the word I'm looking for. So it's ceftriaxone IM plus 14 days of doxycycline with or without metronidazole. Severe cases will require hospitalization with IV antibiotics. So second generation cephalosporin plus doxycycline. Second generation cephalosporin plus doxycycline. So the two that they have listed first are cefotetin plus doxycycline or cefoxitin plus doxycycline. And then it's another option to the second generation cephalosporin plus doxycycline is gentamicin and clindamycin, which is slightly easier for me to remember because usually you use Ancef pre-op on patients, right? We do 1 gram of Ancef, 2 grams if it's a heavier patient. But if we're doing a GYN surgery and the patient is allergic to penicillin, then we use gentamicin and clindamycin. So that's a little bit easier for me to remember. So again, if you want to look into more detail, all your dosages and stuff, the CDC has a really nice table set up for this. And again, surgery is going to be indicated if the patient is unresponsive to those medications. They may have a pelvic abscess, something else that's going on that you need to check out. All sexual partners need to be treated because obviously this is an infection that is passed through sexual contact. So all sexual partners need to be treated with antibiotics. And just a side note, this, like I said earlier that this can be a pretty big issue. And one of the problems I see with this is going in years later to do some sort of abdominal surgery, and it causes all kinds of scarring and all sorts of adhesions inside the abdomen, secondary to this pelvic inflammatory disease, secondary to this infection within the fallopian tubes, just sort of making a big mess out of the abdomen. So this is something and can be very dangerous because patients can get very sick with it. So it's something you want to have an eye out for, something you want to be paying attention to. And again, the things you're trying to separate it from are other pelvic issues. So that ovarian torsion, the appendicitis, things that are going to cause abdominal pain, lower abdominal pain. And the one thing that's really going to help you here is that it's bilateral and with a very active sexual history. Those are 2 things that should be on your exam in the test question that should help you separate this out. All right, so that brings us through ovarian disorders and through PID. We had covered chlamydia and gonorrhea earlier. I think it was episode 9 where we talked a little bit about bacterial vaginosis and all sorts of other fun things there where we talked a lot about antibiotics. So PID will sort of round that category out here and finish that off for us. Our study tip for today, I came across some interesting things I wanted to share with you guys. This is more of a test-taking tip than a study tip. One of the things that I want you to consider and think about is going back and changing answers on your exam. I have never been a fan of doing that. I've always thought it doesn't make a lot of sense. I've always thought it's been a bit of a problem. And I've come across some information lately that helps support that thinking. And some of that information is the idea that you need to start trusting your brain and the things it comes up with. There are tons of things that you know, but you don't know that you know. You're probably aware of somewhere about 50% of the things that you know. And what I mean by that is your brain recognizes patterns. It's great at pattern recognition and predicting things based on those patterns. And that's constantly going on in the background no matter what you're doing. Your brain's constantly searching out these patterns and trying to solve and guess the future things that are going to happen to you and the way things work and answer questions based on patterns it's seen before. At this point, you've seen thousands and thousands and thousands of test questions, and your brain has had a great array of things to look at in order to set up these patterns and identify these patterns. What you would commonly refer to this pattern recognition process as is a gut feeling. You just feel that something's right. You feel that something's wrong, something's off, or something's very, very good, and you don't know why, but you know that it's true. And that feeling comes from your brain's ability to recognize these patterns. Malcolm Gladwell wrote a bestseller called Blink, and in the opening part of that book, he goes through a whole section where he talks about art experts identifying fakes. And he was talking about the time frames and how quickly they could do this. As someone who is an expert in the art community, within seconds and with great accuracy, could identify that something was a faked piece of art. They couldn't exactly tell you why, but they had a feeling and they knew that it was fake. Another example would be how you notice incorrect grammar when someone's talking or when someone's writing. You couldn't tell someone exactly what the grammar mistake was or how to correct it necessarily. Well, maybe you could tell them how to correct it. You couldn't tell them what it was, and you couldn't teach it to someone. That's more what I mean. You couldn't teach it to someone who's learning this as a foreign language. But your brain's had thousands of examples in this repetition, so you know what English grammar is supposed to be like. So you notice when there's something wrong with it. You notice when there's a problem, and you can fix it. But you don't know that you know. You don't know how you know, but your brain does it for you. One more quick example. I was in a case the other day, and a patient had come in from the ER, and actually it was a GYN, it was an ectopic case, So we positioned the patient, we put her up in stirrups, and something was bothering me throughout the whole time we were positioning her. I didn't know what it was. It didn't seem like a big deal, but there was something nagging at me, and it was small, but I knew something was off about this patient. So we're setting up the table. We put her up in the stirrups. I go out to scrub, and I realized once I got out of the room and I was scrubbing, there's a window I could still see into the room from where you scrub, and I realized what the problem was. She didn't have any socks on. Now, every patient who comes in has socks. We use different color socks to denote whether patients have trouble with stability and balance and all those things. But every patient who comes in has 90% of them have yellow socks on that they get. This patient was barefoot, and for some reason, my brain noticed that and denoted it as a problem, as something strange, something weird. My point here is that your brain is constantly working to recognize these patterns and give you information, whether you realize it or not. Let it do that for you during your exam. Let it help you to answer questions during the test. A lot of times when you come to conclusions quickly, it's because you've seen the same questions thousands or hundreds of times, and your brain is already solving them for you. Because you don't consciously are not aware of it, doesn't mean it's not working, doesn't mean it's not there. This is something that I've always trusted during when I take tests. I've always been very good at taking tests. This is and I treat it almost like a skill, being able to listen for that little tinge of why to pick A over B, or why one answer may be better than another answer, even though they look exactly the same when you're trying to break them down. But for some reason, your brain is telling you to pick one and to go with that and let it be. If you're not used to doing that, it can be very hard to let go and just answer the questions. But I think it's something that can be super helpful for you, especially those of you who are not great test takers, is to spend a little time trying to listen to that intuition, trying to listen to that voice, that little tug that's telling you which choice to pick. Because I think that's coming from the thousands and thousands of questions you've practiced with, from all the time you spent sitting in class, that even if you don't consciously recognize it, your brain's picking up on patterns. And you really need to spend some time trying to cultivate that idea and cultivate that ability. I think it can make a huge difference in your test taking performance and something that'll change your scores on test day. It's also the reason why I talk about things like resting the day before your exam and not studying or listening to this podcast on the way into your exam that morning. I think your brain needs rest to do this work. I think you need to let it be and rest it and make sure it's prepared for the exam, because it's going to do a much better job with this pattern recognition, with all of these things, with answering these questions, if you treat it correctly, if you've had good nutrition and you've slept well and you've rested. And I think all of this stuff makes a tremendous difference on test day. All right, I think I've droned on long enough about this. Let's look into our post questions. Following up on ovarian cysts, you discover a small cyst in a 27-year-old female. What's the best initial treatment? I'm going to stick with my watchful waiting answer. What's the hallmark physical exam finding for pelvic inflammatory disease? We talked about cervical motion tenderness. What age group is most commonly diagnosed with ovarian cancer? 60 to 75-year-old women. What two organisms are generally the cause of pelvic inflammatory disease? Chlamydia and Neisseria gonorrhea. So those were all the same from the very beginning of the show. Looks like I was a little lazier here than usual when I put these together. Hopefully you were able to get them right the second time through and really hone in on those answers as we went through those different topics this week. Again, Kim and Val, good luck this week on your exams. Love to hear from each and every one of you as you're getting ready for your exams, after you get your exams, to hear that you passed, even to hear that you failed. I do really appreciate hearing that we're making progress and that you're out there and that things are moving forward. So until next time, good luck to those of you taking your exam this week, and I will talk to you soon. Take care.